Hello and welcome everyone. This is Caleb from Task. We do seem to be having some technical difficulties here. We've located George and he's in the room and we're just trying to get him to be able to hear us and his slides loaded. Yeah, so I'll do just a quick introduction that Dr. Pink is an investigator with the Flex Monitoring Team, is a Humana Distinguished Professor in the Department of Health Policy and Management, Senior Research Fellow at the Cecil G. Shep Center for Health Services Research and Deputy Director of the North Carolina Rural Health Research Program, all at the University of North Carolina at Chapel Hill. Thank you, Dr. Pink, for joining us.
So the COMPASS system has been around for several years. As many of you are familiar with it. This is the first thing that you see. You should have a username and a password provided to you. So you log in and then you get into the system. Next slide, please. The first thing it'll want to know, of course, is to help you get started. You push that button and you will then get the menu page. Next slide, please. Okay, so this is the menu page. So this is where you, as state flex coordinators, can decide what kinds of information, what kind of decisions, what kind of problem you want to analyze. In the top left-hand corner are the bar charts. These charts allow you to graph all of the data for particular indicators, hospital by hospital. So you can see in this graph, it's total margin, and all the hospitals are ranked from the lowest to the very highest. The red line, I don't know if you can see it or not there, that is the benchmark for critical access hospitals that the system uses based on a CFO input that we received a long time ago. The second set of graphs are in the middle, where we want to compare groups of hospitals. So for example, if you want to compare all of the hospitals in your critical access hospitals in your state that have got long-term care to the ones that don't have long-term care, the middle one is where that allows that to happen. The next one is the, sorry, I gotta take my glasses off, is where you want to compare groups of hospitals, and I'm going to go through each one of these in greater detail. The one in the bottom left hand is the financial distress index. Again, I'll go through this in a second as well, but essentially this is sort of this is a forward-looking tool which allows you to assess the current status of financial distress and versus the other indicators which are sort of backward-looking. The next in the bottom middle, the system allows you to download financial data, all of the indicator data for the hospitals in your state. So if you want to do your own statistical analysis, or if you want to present data a certain way, you'll have the raw data to work from. And then finally, in the bottom right hand, this is I think our newest product, and that's really designed specifically for state flex coordinators, which tells you at a glance how the hospitals in your state are doing compared to the national median and so on. So let's go quickly through some of the details here. So some of you who have used the tool for a long time will have noticed now that we've actually changed these are what I call the drawers. We used to have finance, quality, and community. The quality and community has moved to the Flex Monitoring Team site. So this is now entirely a finance site, and which sort of confirms everybody's bias about the dominance of finance in our world. But anyways, the drawers that we now have, we had to think through what would be the best ones, and we've sort of reallocated the indicators to 3 drawers: financial performance, service line, and operations, and I'll go quickly through each one of those. So the financial performance, and you click that on, the profitability indicators, the liquidity indicators, capital structure indicators, these are exactly the same as the ones we have always used in COMPASS. The total margin probably is the most commonly looked at indicator that we have, because it essentially is telling you, is this hospital making money or is it losing money? The liquidity measures essentially measure how well positioned is the hospital to meet its liabilities over the next year or so. And then capital structures essentially tells you how much debt do they have as part of how much of their assets are financed by debt, and whether they have the ability to service that debt or not. Service line indicators, essentially what we decided to do was divide these into two big pots, inpatient and outpatient. Inpatient is increasingly a smaller and smaller portion of the business, so we're trying to think more carefully about outpatient indicators and the best way to measure those. So we've got a separate box now for them. And again, these are all defined in the way we traditionally have. Operations, the box or the subdrawer called growth. Those are all brand new indicators that we've developed in the last 8 to 10 months. We were told that these would be good sort of to help state flux coordinators analyze trends over time. And again, the basic logic here is that you want your revenues to be increasing at a rate per year that's greater than or equal to your operating expenses. The labor indicators are the same as before, as are the other indicators with the exception of Medicaid payer mix, and I'll talk about that in a second. So the new growth indicators, we were told when we did some consultation that they wanted a 1 and 3 year. 3 years sort of gives you the longer term trend. We debated 4 and 5 year long trends, but 4 or 5 years ago it was just sort of a different generation in many ways. But the 1 and 3 year allows you to see, okay, what's the 3 year source? Are we going in the right direction in the long run? And whereas the 1 year says, okay, what's actually happened in the past year or so? So you might be concerned, for example, if you've got a positive 3 year trend, but you've got a negative 1 year trend, that might be more worrying than the other way around, where you've got a bad 3 year trend, but last year has turned up. So you have to really look at these independently. Next slide, please. The other indicator that's brand new in the last year or so is the Medicaid payer mix indicator. Again, we were told that the state flux coordinators wanted more information about Medicare payer mix besides just Medicare, which is all we had for prior. Again, we still have some reservations about the quality of the data that goes into this indicator. The S10 data is still, I think, is still being developed in terms of quality. But right now, that is what we're using. Essentially, it's the percent of total charges that are for Medicaid patients. So when you start getting into the program itself, the first thing it will ask you to do is whether you want to choose a comparator group or not. Next slide, please. Sorry, go back one, please. Yeah, that's it. So here's the choices you have. That you have 3 different categories of net patient revenue: 0 to 10 million, 10 to 20 million, and greater than 20 million. Again, those numbers were based on our statistical analysis that showed that, quote, very small critical access hospitals that got very different levels of financial performance than, quote, larger critical access hospitals. Rural health clinic, long-term care, government ownership also have been shown to affect financial performance. And so you can essentially, with these options, create your own peer groups. And then you can choose the data year as well. So the first types of graphs you can do is the bar out chart output. And again, this chart graphs all of the individual hospitals in your state. You hover over the bars and it tells you exactly what hospitals they are. The red line is the benchmark. And so you can see here about half the hospitals are losing money and about half are making money. Next slide, please. There are essentially 2 control panels on each page. The first allows you to select your own comparison group, peer group, by each of the categories that I described. At the bottom, the menu allows you to do different things. It allows you to change the indicator. You may look at total margin and then want to say, okay, well, what does operating margin look like? So you can change quickly without having to reset everything. Refresh the graph will allow you to, if you change the year, for example, of the same indicator. You can save the data as a CSV, comma separated value file, and then use that in Excel. You can save the image to a PDF if you so choose. You can start a new graph. The indicator definition will bring up a definition written in plain English is what does total margin mean? And then it also has the cost report accounts there as well. And then there's explanations. Sometimes you'll find data that are missing for particular hospitals, and there's explanations as to why that might be. The hospital dashboard shows all the indicators for one hospital on a single screen. So if you want to get the total view of the hospital, this allows you to see everything all at once. And it tells you the percentile. So what it does is it tells you how many other hospitals in the state is the hospital performing better than, or worse than, if you like. So this hospital, you can see on total margin, it's doing very well. I can't see the actual number, but it's doing better than the overwhelming majority of hospitals. On the other hand, on some of the other indicators, which one is it? Outpatient services as a percentage of total revenue, it's not doing as well. So this gives you a nice little snapshot. Next slide. Using a dashboard, you can see each hospital that is listed in your state will be listed there. So all you have to do is go push the dashboard for that one hospital, and the screen that I just showed you will come up. So scrolling over each bar, it gives you a little pop-up box that'll tell you the actual percentile, information about whether it's higher or lower, signals stronger value, stronger performance, because operating margin, total margin, you want that to be as high as possible, but days and net revenue accounts receivable, you want that to be as low as possible. You want to collect your money as fast as possible. So some of these indicators, more is better, some of them more is worse, and the system helps you understand which is which. There are a series of dashboard controls that allow you, again, to choose the comparison. You can compare the hospital to the state averages, or you can look at nationally if you like. You can also change the year, the particular indicators you want to look at, and you can change if you want to look at, well, what does the hospital in the adjacent town look like? You can change that quickly as well. The next one is the Financial Distress Index. This is, I think, proved to be fairly popular with state flux coordinators because it really is a forward-looking tool. We haven't got time to go through all the detail of how this was constructed, but essentially it uses historical, financial, and market data to predict the risk of financial distress 2 years from now. So we're using data up to 2018 right now to predict the risk of financial distress in 2020. And essentially what the model does is it takes financial and market data for 2,300 rural hospitals, not just critical access hospitals, but all rural hospitals. It analyzes those data, and then it assigns every single hospital to one of 4 risk categories: low risk, mid-low risk, mid-high risk, and high risk of financial distress. In the latest run of the model, there are 207 hospitals in the country who are at high risk of financial distress. So the nice thing about it is it gives you probably the top hospitals in your state that you might want to start with or focus on at the beginning. We've done a fair amount of informal face validity assessment with this tool. And most state flux coordinators we've talked with say, when we show you, okay, here are the 5 hospitals that are on our list of high-risk financial distress, usually they'll say, yeah, 4 of those 5 are on, but I also have this one. And the one they usually have on their list is one that might be in response to more recent events than the historical data that we're using. Next slide, please. Using it, so the tool is color coded. So the ones that are color coded red, those are the ones you got to worry about. Those are at high risk. The ones that are green are the ones that you can safely ignore. And then the yellows and the oranges are sort of in between. Again, you want to look for trends in these data. So the hospital at the very top, it clearly should be on your radar screen. It's been at high risk of financial distress for 6 years in a row. Some of these will pop in and out. You can see the one 2/3 of the way down, it was yellow, yellow, then it went up to green, then it went back down to yellow. And that happens a lot with these hospitals because things change over time. Next slide, please. This is, again, if you are Excel oriented and you want to have your own data, you can do this easily. It allows you to download whatever data you want into an Excel spreadsheet. You can add your own data to this, or you can produce your own charts, graphs, and reports as well. You'll only, using the reporting figure, you only see your state. You can choose to filter by peer group factors. The workbook that you get will include 2 tabs. First will provide the indicator values, and then the second will provide the long indicator names and the definitions to help you interpret the data. So you don't just get a spreadsheet with a bunch of numbers. It's very user-friendly to help you start using it right away. The dashboard, again, as I said earlier, it's probably our most recent tool. It allows you to look at how your state is doing at a glance. It's really designed to help you identify potential opportunities for intervention. So if you can see, for example, that that most of the hospitals in your state are not doing particularly well on some liquidity measures, maybe you need to look at some revenue cycle improvement, consulting sessions or information. Maybe you need some consulting work to look at some of the debt management issues that may be happening. It just gives you a way of, again, helping to identify priorities. You can see here in this column that's circled, it tells you what percentage of hospitals in your state are doing better and are doing better than the benchmark. So again, at a glance, it tells you which indicators you should be focusing on and where the potential problems might be. Finally, the net financial indicators chart. This tells you essentially how many hospitals are exceeding the benchmark, and the orange is for those that are not meeting the benchmark. So the ones at the top of the screen, you can probably not worry about those. Again, the ones at the bottom, those are the kinds of indicators that might suggest the kinds of interventions you might want to consider for the state. So how do you go about using all this data? Well, the financial distress index, I would say, is probably the best place to start. Identify the hospitals that are at high risk. You want to look at ones, particularly those ones that have been high risk year in, year out, or in the last 2 or 3 years at a minimum. Those are probably the ones, and I say probably because this is a model, models have error, but these are the ones that are probably the ones that you're going to need your attention. The ones whose risk level seems to be going up over time, you might want to keep your eyes on as well. The dashboard feature allows you to get a snapshot against, so once you have identified the ones you want to target, use the dashboard to look at the hospital's performance across time. You can use the line graph feature, the second one at the top, to examine their performance to groups of hospitals to see whether this is just a one hospital phenomenon or whether it's common to the group they're in. The bar graph can be very helpful. It looks for indicators where they're performing below the national median and below benchmark. This is really helpful if you want to see, is this an outlier in your state or how many hospitals have this problem? These indicators were established at the Financial Summit several years ago. They are not our thinking. They are the thinking of some very smart CFOs who considered all the relevant operating factors and financial factors, critical access hospitals. All of these indicators are in Compass, as well as a whole bunch of other ones. Other things to consider when you're using Compass, System membership is not in the model. We are trying to explore this year a way of trying to get a good measure of system membership. Alternate payment models is not in there as well, so you need to consider that. The county subsidies are not identifiable from the cost report, so if you know they exist, then that's important to consider. And we have very little data for IHS hospitals. Really ask you, this is in my opinion, it's a good system to help you identify questions to ask, issues to address, problems to solve. It will not tell you answers, explanations, or solutions. It's really a signaling tool. Analyses may be reformed if you have other kinds of data as well. So you may want to think about using Compass in conjunction with other data that you have as in your roles as state flex coordinators, and most of them are listed there. Different kinds of interventions will affect different metrics. So if you're doing revenue cycle, you probably want to look at days in AR. If you've got staffing issues, you may want to look at salaries to revenue, and then charge master review will affect revenue and so on as well. We are currently working on a hospital report. Some of you who have been around for a while may remember the old paper version, the old PDF that we used to make available to hospitals and to state flex coordinators. We had requests to have that regenerated, and we will be doing that in the 2020-2021 year, and that will be printable. It'll be very similar in format to the old one. I think that's all. Sorry I had to rush. Sorry for the technical problems. Again, I have no idea what happened.
No problem. Thank you very much, George. Thanks for being here and helping us go through that Compass data. We're a couple minutes away from our scheduled completion of the breakout session, but we can stay in this room for a little while longer and get some questions answered. I do encourage everyone to either type in their questions to the chat box or to unmute your microphone and ask Dr. Pink some questions. The next session will be back in the main portal, correct? Any other questions about Compass, the Flex monitoring team, measures, data reports? I'm really excited about the old hospital reports coming back. I've been at task, so not missing them because I don't have hospitals to read reports of, but I do remember how beneficial those were, and just for my own learning and education as a flex coordinator to understand what these things mean and what I might be able to do or provide suggestions. So I think that'll be a great tool back to have.
That's great. Kristen would want me to say that we're most anxious to get feedback from state flex coordinators. These tools, we're not on the front lines. You folks are in the trenches. We want to be as helpful as possible. So if you have questions, or if you have suggestions, or if you have criticisms, just say, this is not helping me at all. That's the kind of feedback we really need, and we would appreciate.
Yeah, I'll second that. Every suggestion, question, just walking through, say, this isn't as what I would, it's not intuitive to me, but I want to be able to do this with it. Even if it's not possible, it's just understanding for the flex monitoring team what you guys as flex coordinators and the hospitals that use it as well. And we understand there's another step in between, the flex monitoring team to coordinators on down to hospitals. So solicit that feedback and find out what is most beneficial. And always, just like anything else, task at rural center, we can forward that on to the monitoring team and facilitate conversations if needed, or just simply convey messages.
It looks like Dorothy has a question for Dr. Pink. What is the average age or lag time of the data that is included in the reports?
Yeah, that's a good question. And the answer I'm going to give right now is different than what I would have given before COVID, because CMS has just provided an extension to the time deadline for hospitals to submit their 2019 fiscal year end data. So it's normally, there's normally, there's sort of a 6 to 12 month lag. It's going to be a little greater this year just because of all the COVID kinds of circumstances that we seem to be in right now. So I think you should have 2019 data is there for some hospitals right now, but not many. It's going to be a little later than normal. It's one of the disadvantages of relying on cost report data.
And that is one benefit of having Compass and the website, the timeliness of that data. I mean, I remember, years ago when it would take at least a year to get your reports. And now that Compass is there, it takes a fair amount of that time out of that process. You get that data more timely. So that's great. I mean, it is August and we have 2019 data. That's great.
For a few hospitals, not as many as we want.
George, you mentioned that you'll be that the system ownership or affiliation is not in the model yet, but what indicators do you feel are most impacted by system ownership?
It's hard to imagine almost all of them not being affected. When I talk to CFOs, after joining a system, they have greater access to capital. They have visiting specialists on Friday, giving clinics that they've never had before. They have joint purchasing agreements they didn't have before. On the other hand, sometimes the systems close down some services, and so their revenue stream for certain types of services stops and made changes over here. So we've never actually studied it because we still don't have a good way of measuring system affiliation. I mean, most people use AHA. There's some problems with that. We're exploring other options as well. But I would say the answer is I can't think of many that would not be affected in some way. Profitability, capital structure in particular.
Mm-hmm. Okay, thank you. Yesterday, our small group discussion was around the type of TA activities initiative for CHs in systems. And I know the group I was in, the financial piece, and how CHs could demonstrate their value to the system was important.
Yeah, that came up on our discussion as well, Sally. And I'm excited to see how all that stuff comes together and the similarities between the different breakout rooms and what that looks like. I think it'll be a lot more similar than we might imagine.
Yeah.
I'm going to make one final call for questions for Dr. Pink and the Flex Monitoring team. I encourage you to unmute your microphone and chat our questions, or to utilize the chat box there on the bottom, or I guess you can move it where you want. But short of that, we have our final closing remarks from the federal office, starting at 1:15 in the main room. And I just copied and pasted the link again, but that can be found on the portal. Yeah. All right, guys. Well, thank you very much. Thank you again, Dr. Pink. We appreciate it. Please let us know what questions you have, and we can, here at Task, we'll get those figured out for you guys.
Thank you.